Welcome to Oncology Today, optimal management of squamous cell carcinoma of the anal canal. This is medical oncologist Dr. Neil Love. I met with Dr. Marwah Fakih from the City of Hope Comprehensive Cancer Center in Duarte, California, to discuss current management approaches for squamous cell carcinoma of the anal canal, or SCAC. To begin, I asked Dr. Fakih about the incidence of SCAC and why it's observed more frequently in women.
That's a great question. It's actually always been higher in females than males. And I mean, I'm assuming that partly it's HPV-driven infection in that setting, and it's probably a little bit more so colonization of HPV. That's the, in my mind, the only explanation. If we factor in immune deficient incidences and HIV on top of HPV, then you'll start seeing a higher incidence in men because of the prevalence of HIV. But this is an HPV-driven disease.
You had listed anoreceptive sex as one of the factors that increases incidence. Has that been looked at in the women who are diagnosed, and what's the mechanism by which anoreceptive sex does that? It's just transmission of HPV?
Yeah, it is largely transmission of HPV. And I think, when you look at these, risk factors, frankly, many of these risk factors are somewhat confounded by other risk factors, right? Because it becomes a question of, how much of it is it associated to the, for example, in men, to the really higher risk of getting HIV in the setting of HPV in that setting, and what if you do protected, anoreceptive sex? Does that really increase the risk, and why should it? I mean, and the answer would probably not. And I think at the bottom line is that it's HPV associated with other confounding immunosuppressive factors, and the combination of immunosuppressive factors plus HPV increase your risks, and you're going to be finding association with behaviors that link those together, which gives you that association, but not necessarily a cause effect.
What is the current utilization of HPV vaccination? Sort of when did it begin, and how long of a period is it between vaccination and what you would expect to see in terms of reduced incidence? And how much of an impact has it had so far? You were mentioning that it looks like maybe in younger people we're seeing less. When would you expect it to peak, so to speak?
Yeah, I mean, I think if you, first of all, I think the problem is going to be how many people do receive the vaccine. I mean, the treatment and the vaccine and the prevention is only as effective as it is being endorsed. And I think you're seeing that, some individuals are not being vaccinated. Some don't have access to health care, unfortunately. It is, socioeconomic factors. It's awareness. It's education. Sometimes it's vaccine phobia. And but the recommendations is both that teenagers do get vaccinated, whether it's females or males with HPV vaccines, and knowing that this is a disease that typically affects people in their 60s and 70s, right? That's your bulk of your patients and older. You'd expect that when you start vaccination, the impact is going to be really more than 30 years later from an implementing a strategy. So I don't think we have really hit that sweet mark where we're going to see the benefits from the vaccines that much yet. And I think that's the reason why the projection, when I mentioned 2032, that some subgroups will have some reduction in incidence, is related really to that. And those subgroups that would benefit are those who are getting more access to the vaccination.
Another thing before we get into the really exciting data here now with IO plus chemotherapy, just kind of curious in terms of kind of the pattern that happened with cervical cancer. Are there studies right now combining IO or using IO with chemoradiation?
Yeah, great question. Not that I'm aware of as far as phase 3 trials, right? And I think the pilot trials are not going to really take us that far in that particular setting. I think where there is interest with chemoradiation is, can you de-intensify radiation therapy for lower risk individuals? Do you really have to give them the highest dose feasible? There are some concepts being floated and ideas regarding even using IO early on as a strategy in patients with squamous cell cancer of the anal canal. But whether that can be more of a neoadjuvant strategy or a definitive strategy with a window of opportunity for observation before you do chemoradiation. But those are all on the concept stage, and I don't think we will have an answer anytime soon about integrating IO with radiation.
Any interest or any work being done on cell-free DNA, MRD assays in either localized or metastatic disease?
Yeah, there's definitely been some work. Natera, which has the Signatera assay, has some data reported from retrospective analyses from single centers. There's also the HPV PCR, HPV DNA PCR that you can follow as well, and that has been validated as well in some smaller trials. I don't think that there is strong enough data as to what is the sensitivity in this particular setting. We don't really have well conducted prospective powered studies given the rarity of this disease. I have used it in some patients, and however, the reality, it's the standard right now continues to be imaging and local assessment for patients with in remission. Obviously, I don't think it has a role in the follow up of metastatic disease. Those patients should be followed by imaging.
Also curious how often you see local recurrence. It looks like it wasn't that common in the trial, and do you see uncontrolled local recurrence as a palliative problem in patients with advanced disease?
Oh, huge problem. I mean, I think because there's probably more local recurrence than there is, there's as much as local recurrence in the pelvis or more than there is upfront metastatic disease. And that can have a significant quality of life impact in those patients because these tumors are locally advanced, destructive, associated with pain, symptomatology, such as edema and radiculopathy, et cetera, and become really harder to palliate because you can't really, resect them appropriately. And at the same time, you've done your chemoradiation. So yes, we continue to see that as a problem. Also, it's really stunning, actually, to see this OS follow-up with 10 months. It's interesting, how in general, it looks like maybe IOs in general and seem to be more effective in squamous cell. You see that in lung and head and neck, but 10 months overall survival improvement is really stunning. What do we know about the quote tail on the curve there? Maybe it's a little early now, but any thoughts about to what extent we are going to see or we are seeing a tail on the curve and how big it is, and are we potentially curing some of these people? I do think we're curing some people. I have no doubt. I see it in my practice, and frankly, you could even see cures with chemo alone in patients with squamous cell cancer of the anal canal. This is a chemosensitive disease, and I think the bigger the tail or the higher the tail of the curve, the better it is, and the more that we're going to be seeing 5-year remissions. Whether it's going to be at the end of the day a 5-year 15% ongoing CR or not, I think we'll see the further follow-up from the study. But I do believe that some patients with advanced squamous cell cancer of the anal canal are curable. Now, interestingly, there are some data that suggest that it is also dependent on the pattern of metastatic disease. So if I look at the patients where I have seen more cure, it has been patients with lymph node only metastases, for example, or patients with limited lung metastases and distant lymph nodes, and we've seen that also with immunotherapy alone, and so it's a little bit less likely that you're going to have somebody with 20 lesions in the liver have an ongoing remission, but not impossible. I mean, I can tell you from my own experience, we've had patients with bone mets, liver mets, and lung mets who have survived 6-7 years and had chemo-free intervals of 2 years after excellent induction treatment for their metastatic disease. So I think the message for the community physicians and for our fellow oncologists is that really be aggressive in the management of this disease and use combination therapies because patients can do well. Neil, we've also integrated in some patients with oligometastatic disease, SBRT in some patients. When you have somebody with multiple lesions, and this is again personal experience, when you've had a complete remission except for one spot, and that's the only spot, and you followed and you don't see anything else. And some of these patients, you don't have to jump back on more systemic chemo. You can monitor, you can control. I have to say there's some role also in some patients with oligometastatic disease to the liver for surgery. We've had some patients who've had 1 or 2 liver metastases where we've had hepatectomy performed, and these patients, many of these patients are cured. And so I think brings up the importance of multidisciplinary management in metastatic squamous cell cancer of the anal canal.
How often do you see brain mets or CNS involvement?
Not common with this disease. Yeah, not common. If we see it, it's usually very late, right? When the disease now is completely out of control and it's multi-organ involvement, but not early on.
And kind of getting back to this issue of maybe cure or long-term outcomes. How do you approach the issue of duration of the IO, the retifanlimab, in patients who are doing well?
Yeah, no, that's a great question. Now, the Podium 303, the duration of retifanlimab was 1 year. So if we follow the criteria of the study, we really hold it 1 year. But I have to say, I mean, if I do have a patient with a partial response where I'm convinced that there's still active disease and I'm controlling their disease with PD-1 monotherapy, do I really want to stop? As a treating physician, I don't want to, because I am concerned if there is a significant measurable disease. Say I've done a PET scan now and it's still FDG avid, so I'm confirming that this is measurable disease that is not fibrosis, and the patient has several target lesions. I would probably sit down with the patient and go over risks and benefits and say, hey, we can stop, but there is a chance it could progress. We don't have really enough data at this point as to what is the duration of, stable disease in patients with active metastatic disease on PD-1 if we withdraw. And there's the risk of ongoing, PD-1 targeting associated toxicities, which in my opinion would be low with monotherapy at that point. If it's me, I would want to continue.
So we were just at the GI ASCO meeting there, and first-line therapy of gastroesophageal cancer in PD-1 positive patients looks like it's going to change to zanidatamab plus IO, but the IO used there was tislelizumab, which is not commonly utilized in the United States, and people were bringing up the question of could you substitute Pembro or Nivo in that situation. What about here? I noticed that the data with Atezo didn't look that great. You see that sometimes, PD-L1 versus, PD-1, I don't know, but any thoughts? What would you say to somebody? I thought usually people stick with whatever, is used in the trial. Like in lung cancer, durvalumab worked in stage 3, so that's what they used. Do you think that retifanlimab should be used in these patients, or would it be reasonable to switch to another IO?
I mean, there is a study with Nivo that has been completed, which is carboplatin, paclitaxel, nivolumab in squamous cell cancer of the anal canal. That's in NCI-sponsored phase 3 trial that will give us another answer. I think you can make the argument that on the phase 2 trials, at least looking at the PD-1s, they appear to have similar efficacy. At this point, retifanlimab is FDA approved. The data is with retifanlimab. It's a level 1 evidence. I personally would use retifanlimab, but can I say that, pembrolizumab or nivolumab may not result in an equivalent efficacy? I would say it's likely could have similar efficacy, right? I mean, based on what we know. Atezolizumab, it's a little bit different story. I don't think I can make that big of an extrapolation, frankly, because as you have stated, the data did not pan out with atezolizumab in other situations the same way that it panned with others, and it could be disease specific or something. I don't know. I mean, we've recently seen some data with atezolizumab in MSI high stage 4 colon cancer that was on the COMET trial that was surprisingly less than one would have expected. So I think there should be a higher burden of need for evidence with PD-L1s if you want to extrapolate to PD-1s, in my opinion.
Speaking of MSI high, I'm assuming you don't ever or rarely see that.
I have not seen a single one. Yep. No, it's very uncommon. I mean, I wouldn't say it's impossible, but it's very, very rare, probably 1% or less. It's not common to see MSI high positivity here. And it's a disease that doesn't really have much of targetable alterations either. You do see some PIK3, I think, but there's no evidence at this point that is a valid target for this particular disease.
All right, let's talk a little bit about your cases, beginning with the 64-year-old woman. What happened with her?
Yeah, so let's start. Let's talk about a few cases. So this is a 64-year-old female with a history of smoking, hypertension, had blood per rectum in 2023, and had further workup, and was noted to have by rectal exam a 3-centimeter mass in the anal canal. Had further imaging and was noted to have perirectal lymphadenopathy. But no other distant disease. Her clinical stage is T2N1A. Biopsy confirmed invasive, moderately differentiated squamous cell cancer of the anal canal. So the question becomes, what is the best treatment for this patient? And the answer here is chemoradiation is the best answer. It's not systemic chemotherapy. We've looked at those previously as a community, as an oncology community in randomized phase 3 trial using cisplatin 5-FU prior to chemoradiation. Does not result in a positive impact. This is not stage 4 disease. This is not a locally advanced, previously treated anal cancer. So the data from Podium 303 does not apply here. And the data supports that you need both 5-FU and mitomycin C or capecitabine mitomycin C, and that's by extrapolation, in the management of locally advanced or localized anal squamous cell cancer. So a capecitabine monotherapy or 5-FU monotherapy as far as systemic treatment plus radiation is not sufficient. Has to be the combination of a fluoropyrimidine, either 5-FU or capecitabine, plus mitomycin C and radiation. So that's what this lady received.
Could I just ask before you go on, just kind of curious, for a patient like this with stage 3A disease, what do you advise in terms of the likely risk of recurrence after treatment?
Yeah, so this patient is highly curable, and I think with the size of 3 centimeter and a local lymph nodes, not iliac lymph nodes, probably more than 80% chance typically these patients to achieve a cure.
So I see, unfortunately, she ended up having recurrence.
So this patient recurred, and the recurrence was local, and a biopsy confirmed a P16 positive poorly differentiated squamous cell cancer. And then, how do we manage this patient? Well, we stage them. Since there's no evidence of any metastatic disease, cure is the goal still. And so, you're not going to achieve a high dose enough of radiation here. And this patient has progressed following radiation. Systemic chemotherapy is an option if it's not a curable disease surgically, but this is curable surgically. So you recommend APR resection. And that's what this patient had, an APR resection with a permanent colostomy.
Again, in this situation, what would you advise the patient who says, okay, what's the chance that I'm going to have recurrence after this?
It's still relatively high as far as regional recurrence and pelvic recurrence in patients receiving salvage APR. It really all depends on how localized the disease is. Is this something getting closer to the coccyx, for example, pelvic sidewall? Unfortunately, some of these recurrences are not just mucosal, but are deep. And so the staging of the disease and the ability to get a radial margin negativity is really what's going to impact the outcome. Also, if you have a pelvic recurrence with multiple lymph nodes bilaterally in a patient who already had chemoradiation, that's also bad. Now, unfortunately, a big chunk of patients have either a bulky recurrence or bulky adenopathy. And in that setting, recurrence is more than 50%. And most of these patients will have pelvic recurrence, unfortunately.
So, and again, unfortunately, she did have a recurrence after this, not that long after. It seems like just a few months later.
Yes. So this patient had and this is the problem that I mentioned earlier, the radial margin. So her radial margin was within 1 millimeter. And you can see that the tumor was bulky. If you catch a recurrence and it's 1 centimeter local recurrence, a very high cure rate, but this is not the case here. So this patient had an APR resection, was followed by PET-CT imaging after her resection, and unfortunately had further recurrence in the pelvis with a presacral nodular mass, 1.5 centimeter. And at this point, this patient is not curable with surgical intervention.
I see that her PD-1 was increased. Do you know the level?
My recollection is that she had a CPS of 5.
How correlated is benefit with the magnitude of the CPS? 5. How high do you see? 20, 50, et cetera?
You can see 20. I think most of the cases that I have encountered is really a modest increase in CPS score. Somewhere around 5 to 20 is the majority of the cases. I don't think we have enough data stratified like has been the case in gastric cancer by say TMB of more than, CPS more than 10 and 1 to 10. And so, and partly because we don't have the number of patients who go on studies that we have with other tumor types.
Just curious, is cryotherapy ever used in this disease?
No, that's not really a standard of care in this disease.
So you bring up the question of the optimal therapy, and I think your talk's pretty clear about what would be optimal, carbopaclitaxel, retifanlimab. Just kind of curious, before you tell us what happened with the patient, we look across the United States, do a very high fraction of people in this situation get this therapy, or is it not getting picked up exactly?
I think it's starting to get picked up because the approval for retifanlimab, was only recent, approximately, I think 6 months ago or so. And so the awareness has increased, and I'm hoping as individuals know more about the Podium 303 and listen to your program that we will have a higher uptick.
So what's the follow-up on this patient? What's their current situation?
This patient has completed now 6 months of carboplatin and paclitaxel and has had a partial response to therapy and continues on retifanlimab.
How has she tolerated therapy?
So from the retifanlimab perspective, no side effects really, but from the carboplatin paclitaxel, as we expect with everybody, fatigue, everybody gets the hair loss, and then the neuropathy starts kicking in around the 4 to 5 months mark in these patients. But once we stopped systemic chemotherapy and now on a treatment holiday, she's doing extremely well. We also saw some anemia in her case.
I don't know how well this next issue is actually being studied even in lung cancer, but just kind of curious, any evidence or you have any clinical thoughts about correlation between autoimmune toxicity and benefit from IOs in this situation?
I don't think it has been looked at specifically in squamous cell cancer of the anal canal, to my knowledge, but I would expect to see some correlation because we really see it across all tumor types.
All right, 66-year-old woman.
Okay, so this is another 66-year-old female. Again, rectal discomfort here and intermittent bleeding and dragged for almost 18 months. She sought a medical opinion, was found to have a quite a bit of large tumor involving the anal canal. Colonoscopy showed that this is 6 centimeter in size. P16 positive. PET-CT shows a significant bulky left inguinal lymphadenopathy. Clinical stage T3 and positive. And this patient was treated with standard of care, capecitabine, mitomycin C, and radiation therapy, and completed therapy in August of 2024. 3 months later, had a partial response. Now, with squamous cell cancer of the anal canal, it's important to note that you may not have your maximum response until about 5 months from completion of radiation therapy. So you don't make decisions on surgical management in these patients at the 2 or 3 months mark. The patient waited 2 months, February 2025, was noted to have persistent disease in the left inguinal area. But at this point, this disease in the inguinal area has encased the left femoral artery and vein and had resulted in superficial bony invasion, and was evaluated by surgery and was deemed non-operable. Her primary tumor itself had minimal residual disease, and she had no GI symptomatology. So that's when this patient presented to us for an opinion. And the next best treatment here in this patient would be, again, based on Podium 303, carboplatin, paclitaxel, and retifanlimab. The patient, unfortunately, moved out of the country and did not receive PD-1 therapy and opted for systemic chemotherapy and received carboplatin paclitaxel, achieves an objective response after 4 months of treatment, but 2 months later has progressive disease in both left inguinal area and with new lung metastases. So here's an example of where you have a patient who had systemic chemo alone, and I would say here, Neil, all the options of all PD-1s are acceptable, whether it's nivolumab, pembrolizumab, retifanlimab, and nivolumab plus ipilimumab would not be an approved or an acceptable combination because we have a negative study showing no substantial improvement by adding ipi to nivo.
So what's the patient's current status?
This patient is not following with us, so I think the last we left her is she was starting on nivolumab closer to home.
I think from the data you presented, utilizing IO monotherapy, you would expect things are not going to go too well. I guess, do you ever see a prolonged, survival there using it in recurrent disease?
I do, and as I said, interestingly, there's a correlation with site of metastatic disease and bulkiness of disease. So we have, in my practice, there's at least 4 patients that have complete remission with distant retroperitoneal lymph node involvement with PD-1 therapy. So, we've seen that with other tumor types as well. The site and bulkiness of the metastatic disease can affect the response to IO therapy.
I wonder if her docs in Canada wanted to give her retifanlimab, but maybe it's not approved in Canada. A lot of times they sort of lag behind.
Well, at least when we consulted on her, it was not. Okay. Yeah, this is also a patient in the 60s, diagnosed with a T2N1 squamous cell cancer of the anal canal. This patient refused chemoradiation and was lost to follow up. And unfortunately, this is not too uncommon with anal squamous cell cancer of the anal squamous cell cancer. And a lot of patients, or at least some patients, refuse categorically the any intervention that may result in dysfunction of the sphincter, have some fear of chemoradiation, and some who have who need APR after chemoradiation results in an incomplete response are declining surgical intervention, which only causes more problems down the road. So this individual lost to follow-up, presented back 2 years later with rectal bleeding, worsening pain. Staging her, she had a left supraclavicular lymph node involvement. She had a retroperitoneal lymph node involvement. Her primary tumor was 5.2 centimeter in the setting of perirectal adenopathy. And this is a patient who presented with stage 4 disease, and we treated this patient prior to retifanlimab being approved. She presented early in 2024, and she received 8 cycles of modified DCF. And as you can see, she had a complete response by PET-CT in September of 2024. At that point, because of her residual disease in the anal canal, the patient proceeded with chemoradiation to the primary tumor with mitomycin C capecitabine RT, completed that in October of 2024. And this patient has been off any treatment since October 2024. I saw her in clinic about a month ago, and she continues to be NED. She's having PET scans on a routine follow-up and anoscopy with surgery. So that's an example of a patient who has a great response to treatment, and an example that you can get durable remissions in patients with anal squamous cell cancer. Now, if this patient were to recur, and hopefully she doesn't, the question becomes, what do you proceed with? And from what I see is a patient who had a very sensitive response to modified DCF. She would be non-platinum resistant, and she would be PD-1 naive. And I think this is a patient that I would treat as a patient with first-line treatment with carboplatin, paclitaxel, and retifanlimab at that point.
What fraction of patients have PD-1s of 0? And are these people, do people ever offer IO?
Yeah, I think with retifanlimab data, you could see some discordance in the benefit between PFS and OS on the data, but you do see some benefit on the PFS side, and I think you have to give the patients the benefit of the doubt. I certainly don't see how big of a difference is between a CPS of 1 and a CPS of 0. To be honest with you, and the relative low toxicity associated with PD-1 would really steer me to not use that against them in offering them a retifanlimab in the first line.
Is retifanlimab being studied in other cancers?
At this point, I am not aware of additional registrational studies. There have been multiple prior studies in the past with retifanlimab, but I am not aware of large-scale trials right now with retifanlimab.
Any ongoing trials, new agents, new strategies being looked at in this disease that you're excited about?
Yeah, there's been some work with T-cell therapies in the past. There's been some work with vaccines. Unfortunately, some of those programs have not fully panned out. I still think there is a role to look at ADCs in squamous cell cancer of the anal canal. There are some other novel bispecific antibodies that are making their ways in other solid tumors, and I foresee that possibility. EGFR targeting has not really panned out fully in that in squamous cell cancer of the anal canal, but there are some novel strategies around EGFR as well. But I would label all that work to be in early clinical trial development.
Anything we haven't talked about that you want to comment on? Any myths or misperceptions you see in community-based oncologists about the disease?
I mean, I think the biggest thing is the importance of early intervention in metastatic setting and keeping an eye on the possible curative outcome in some patients. The 5-year survival is a possibility for this disease. And I'm not saying for everybody, but for some, and you don't want to miss those. And I think the multidisciplinary approach in some of these cases, especially the oligometastatic disease, is extremely important.
That's really a great point. We did a webinar recently, and I was kind of really surprised. We did it on small cell carcinoma of the lung. And the investigators were saying that, because when you look at extensive stage disease, you see that PD-1 agents combined with chemo seems to have a benefit. Most people do it, but like when you look at the curves, not nearly as dramatic as the data you just showed. But then they showed me that there's a convincing 12, 14% 5-year survival in these patients. Mm-hmm. And there's a lot of debate about how aggressive to be with these patients. They have some new data now looking at chemo in the maintenance setting. But to me, if you have a chance of cure, it really changes the whole outlook of how you see the disease. So I think it's a great point that you bring up, because I'm not sure everybody realizes you may see, pretty dismal overall outcomes. But when you start seeing a clear-cut tail on the curve, and it looks like it's there here.
Mm-hmm. Yeah. No, absolutely.
This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. And keep in mind that the use of agents and treatments that are not approved may be discussed in this program, so check out the package inserts for more. Special thanks to Dr. Fakih, and thank you for listening. This is Dr. Neil Love for Oncology Today.